Hello, everyone. My name is Ed Stever. I'm the president of the National Foundation of Swallowing Disorders, and I'd like to welcome you to today's webinar on Parkinson's disease and swallowing disorders. So, the mission of our foundation is to provide support, education, awareness, and research around the topic of swallowing disorders. I'd like to give just a few brief examples. In the area of support, we refer about 300 patients worldwide to specialists in their geographic area. We also have a very active pediatric support group on Facebook. It has about 1,200 members and about 400 comments or initial posts are posted every month. So it's just a great place for people to connect. In the area of education, we do things such as this webinar, awareness. June is National Dysphagia Awareness Month, and we have a campaign running right now and expect to reach over 1 million people this month with facts about dysphagia. And we also support research. We published a paper, or we helped fund a paper that was published in the diseases of the esophagus that really looked at the cost, hospital length of stay, and other factors tied specifically to dysphagia. During tonight's webinar, you will be muted, but we really encourage you to ask questions. And so you should see a blue question mark on your screen. And you can type that at any time. Mary has worked in 2 brief breaks during her presentation, and then we'll answer questions at the end. But please feel free to really take advantage of this opportunity with Mary as we're live, and I really think it's one of the nice things about a webinar, that's being able to ask questions. You'll also see on your toolbar a place to download a PDF. And it's really a very brief summary of the information that's going to be covered tonight. The slides will not be provided, but we're hoping the PDF will provide you with the information that Mary wanted to share as takeaways from tonight's webinar. I'd like to thank Bracco Diagnostics. They have provided our foundation with an unrestricted educational grant for about 4 years. And we use that grant to help host these webinars. And lastly, this is National Dysphagia Awareness Month, and there is a way for you to help, and it won't cost you a penny. If you go to our Facebook page and you share the photo facts that are on that page, the people who are sponsoring them her free to donate money to the foundation for every share that you make. So I really encourage you to go out there, look through the photo facts, and share them as much as you can, and your network of people can share them. I'd like to briefly introduce Mary Spermuli. She's been a healthcare provider for over 30 years, currently in the Southwest Florida area. She's a licensed speech-language pathologist in a number of states, and she keeps a very active blog on her website. So if you go to her website at Voice Aerobics, you'll be able to see a blog that Mary keeps. And it's worth spending a little bit of time and seeing that. So at this time, I'm going to invite Mary on and have her take it away.
Okay, hi everybody. So let's see, let's get me off of that middle of that screen. All right. Hi everybody. So can you hear me? Hopefully. And yes.
Yep, we can hear you. Good.
Okay, great. Hi, everyone. So I just want to begin first by thanking Ed for his leadership of NFOSD and for the invitation to speak tonight. And also, I'd like to thank Elizabeth for her help in getting this webinar online and for keeping it online tonight. You always worry about the technical piece. When I was invited to do this webinar, I shared with them that I am not an expert in swallowing. I don't give myself that title. I have friends and colleagues who are well deserving of that and who have spent much of their career doing research in that area. But over the last 25 years or so, I do believe I've gained an expertise in the area of Parkinson's, in part because of a very strong clinical interest, and also in part because of the people I work with. And that includes a local neurologist who I met 30 years ago. But in the mid-1990s, when we were beginning to see a lot more patients with Parkinson's, he and I professed to one another our love of working with patients with PD and our commitment to provide them the highest level of care that we could in our community. And in order to do that requires really never-ending learning. So about 10 or more years ago, we started a monthly journal club where we come together as an interdisciplinary group and share articles from a variety of our journals. And I know that that has contributed tremendously to my ongoing learning. And then I learn the most from the people I see every single day in my office. So, alrighty, so I'm gonna get going here. And I just want to make a couple of comments in terms of disclosures. I have no financial or commercial interest in NFOSD. I am a member of the Medical Advisory Council of Neuro Challenge Foundation. That's a non-for-profit based out of Southwest Florida, but serves a 5-county area actually in Central and Southwest Florida. So we're very fortunate in this area because they provide educational programs, support groups, and care advising. So if you visit Florida in the wintertime, I hope that you'll take advantage of some of those programs. I'm also a member of the Education Committee of the World Parkinson Program. That's a Canadian non-for-profit. It was founded by Dr. Ron, a renowned neurologist, who believes that education is the most important thing that we can give our patients. So towards that end, they published their literature in 15 different languages. But even more important than that is the true mission that they have, and that's to serve people living in poverty throughout the world. I think we're so lucky here in the United States, we don't even think about or imagine the thousands of people worldwide that have no access to neurologists or other healthcare professionals, that have no Parkinson's medication or even simple devices that might keep them safe in their environments. I hope you'll visit their organization as well. And then finally, I just want to thank my patients who've allowed me to use little video clips tonight. Some of their photos interjected throughout my presentation, and to a friend and colleague, Debbie Tarakoski, who's owner of Swallowing Diagnostics, who helped me put together some little video clips tonight. I'm not going to go through the learner outcomes because you've read those when you registered. I'd like to just begin by a little terminology. And actually on the left of the slides is some terminology for the speech pathologists, the students, and terms that you might hear from patients or that you might read. So tonight I'll primarily be talking about idiopathic Parkinson's, or what I say to my patients is just good old Parkinson's. You'll see it abbreviated as PD. That will encompass patients who were diagnosed at a younger age, so young onset Parkinson's disease. And idiopathic means we really don't know what the origin of the disease is, with the exception of about maybe 10% where there is a genetic association, and that usually is in the young onset Parkinson patients, usually with a strong familial relationship. And then you'll also have patients say to you, or you may read in a report where they have a diagnosis of Parkinsonism or Parkinsonian features. What does that mean? It means that the neurologist has not yet arrived at a definitive diagnosis. It might be an early presentation of a Parkinson plus diagnosis. It may be Parkinsonian because the etiology is more vascular in origin. Sometimes these folks don't respond in a very robust way to the carbidopa medication when you ask them, but they're going to have a lot of features of Parkinson's. And then finally are the Parkinson plus or atypical Parkinson's diagnoses. Again, I'm not going to really talk about them specifically tonight, but I do want to say a few things at this point. So that encompasses three broad diagnoses: progressive supranuclear palsy, PSP, multiple system atrophy, MSA, and cortical basal degeneration. And even within those diagnoses can be some subgroups. Not all things that look like Parkinson's turn out to be Parkinson's. And so sometimes you may see a patient who will come to you and they might be a little annoyed because their doctor last year told them they had Parkinson's, and now this year they're being told they have PSP. It's not because their doctor was bad or wrong. It's just that sometimes it takes time for the disease to emerge and take shape and to get a more definitive diagnosis. But I will say this, I think speech language pathologists can play a really key role in helping with a differential diagnosis, because one of the things that is different with each of these disease diagnoses is the presentation, particularly motor speech presentation. They may have some hypokinetic dysarthria, but often have some other motor speech features, which if you become familiar enough, you will begin to distinguish. A patient with MSA, for example, with cerebellar involvement is going to have more of an ataxic dysarthria. So we can really help with our input and our evaluations, help perhaps with an earlier, more accurate differential diagnosis. And then the other thing I'll say about all of the atypical Parkinson's, they all will have speech and swallowing symptoms, usually very early in the disease, and those symptoms will progress at a much faster rate, a much more aggressive rate than you will see with patients typically with idiopathic Parkinson's. Now onto the right side of the screen, a few terms for people who might be listening tonight who have Parkinson's or are care partners, and I understand we have some people with PD, so I'm very happy about that you're here learning tonight. So dysphagia is just the broad term that has to do with the ingestion of food from mouth to stomach. Oral pharyngeal dysphagia is usually the realm of swallowing that speech language pathologists have for the last 30 or 30 plus years been interested in. But we know that swallowing doesn't stop until food gets out of the esophagus and into the stomach. We are also interested in esophageal function, and patients with Parkinson's frequently have esophageal dysphagia. So both evaluation of both are going to be important. You'll hear me mention tonight, certainly more than once, about the importance of instrumental swallowing assessments. None of us has X-ray vision. I can't even imagine at this point in my career beginning treatment of a patient without having access to an instrumental evaluation. And that could be a video swallow study, a modified barium swallow study, or what we call a FEES, fiber optic endoscopic swallow study. Little scope in the nose, visualizing the larynx and the swallowing from that view. And then finally, aspiration, the elephant in the room. I think the scary thing that people read about when they are diagnosed with any type of neurodegenerative disease. And of course, I will talk about that as we go along tonight. So this spring, at a very large expo for people with Parkinson's, with over 1,300 people in attendance in Sarasota, Dr. Michael Oken, who's the movement disorders, head of the movement disorders program at UF, referenced this article, fairly recent article that had been in JAMA Neurology, talking about the Parkinson pandemic. So when we talk about an epidemic, usually it is referring to an infectious disease that has a global spread. But in this case, we're talking about a pandemic because of the exponential growth or expansion, I should say, of Parkinson's worldwide. It now surpasses Alzheimer's as the fastest growing neurological disorder. The number of people with Parkinson's in the next 20 years is expected to double. So you see from 6.9 million in 2015 to 14.2 million. Now, I should say that I don't think I'll be practicing 20 years from now, but I'm sure that many of you listening, particularly the students, will be in the height of your practice 20 years from now. And while I don't have a crystal ball, I think I can safely say that if we don't have a cure for Parkinson's, I think they'll be awfully close to it. And there certainly will be symptom management that we probably aren't even imagining yet as we all sit here tonight. So I think the best is yet to come as far as what's in the future for people living with PD. Just recently, the Michael J. Fox Foundation revealed some numbers of the true kind of numbers of the economic burden of, I know Ed mentioned a little bit earlier, the economic burden of dysphagia, but 52 billion is what was the number of what Parkinson's basically costs certainly in terms of financial costs, but we all know the economic cost is really not a calculable cost. So depending on who you read, anywhere from 80 to 100% of people with PD will develop dysphagia during the course of the disease. 80% seems to be a pretty accurate number. And you know, because you've come to these webinars before and because of the work you do, or maybe you're living with swallowing problems, regardless of the cause, swallowing problems impact quality of life, create problems with nutrition, and sadly, in the realm of Parkinson's, it remains, aspiration pneumonia remains the leading cause of death in PD. Well, I'll talk a little bit tonight is what we understand about the pathogenesis of Parkinson's and how that interfaces with dysphagia, but we do seem to understand now that there are dopaminergic and non-dopaminergic mechanisms that are involved. So that means problems related to the loss of dopamine from the basal ganglia, as well as some brain pathology outside of the basal ganglia. So idiopathic Parkinson's is a slowly progressing neurodegenerative disease. After the age of 60, about 1 to 1.5% of people will be affected. I mentioned that young onset Parkinson's is usually a diagnosis of below 50 years of age. And there's actually even juvenile form of PD, fortunately fairly rare. And Parkinson's is characterized by a premature loss of dopamine neurons and the accumulation of Lewy body composed of alpha-synuclein. Alpha-synuclein is a protein but when it begins to go awry, it clumps or there's aggregates of it. And we now know through research that those Lewy body protein are found in multiple systems throughout the body, not just in the basal ganglia. So the main goal of medical treatment is to replace the dopamine that is being lost, and then through other means like DBS to try to modulate that dysfunctional circuit. Autonomic dysfunction, which I'll again elaborate on in a moment, it is also very prevalent in patients with Parkinson's, and also thought to be related to some pathology outside of the brain, including the spinal cord and the peripheral nervous system. I already mentioned about 80% of persons with PD will develop dysphagia. That same range, 70 to 90% of voice or speech impairment. And actually what I think is in a way most interesting is that based on some of the current models of the pathogenesis of Parkinson's, voice and swallowing changes are thought to be some of the early premotor, what we call prodromal symptoms, meaning that the changes in those mechanisms is happening many years perhaps before the motor symptoms of the disease manifest. So that has important implications for biomarkers. I'm sure that there's researchers even within our field who are currently doing some research to identify ways that voice analysis or swallowing analysis could be used as a biomarker to detect earlier someone who might have Parkinson's. And I think it also has important implications for neuroprotection and the role of exercise. So in the early 1800s, when James Parkinson first described the shaking palsy, he actually described a lot of the symptoms that today continue to be the cardinal symptoms of motor symptoms of Parkinson's. So they are bradykinesia, which means slowness of movement, rigidity, stiffness, so those are the kind of key motor features, slowness and stiffness, postural instability, and tremor, usually a resting tremor, and usually in its onset unilateral. The diagnosis of Parkinson's still today is primarily one of a clinical exam. And so that's again another reason why sometimes these Parkinson-like look-alike diagnoses can be a little bit hard to distinguish. When you read your patient's reports, or if you are a patient, when you go for your visits to your neurologist, they will use the Hoehn-Yahr or UPDRS scales as ways of measuring where you are at, staging you, basically where you are at in the progression of the disease. But over the last 2 decades, really, I would say, since probably early 2000, one of the biggest shifts in understanding Parkinson's has been in the awareness of the non-motor symptoms. And so the motor symptoms are really kind of the tip of the iceberg, if you will. And beneath that lie all of the dysautonomia or the autonomic nervous system impairments or problems. So on the right side of your screen, you see I've listed some of those. We start off with the hypos that we as speech pathologists are pretty familiar with. Hypo is a prefix that just means low. So hypophonia, low volume of voice. Hypokinetic dysarthria, just a broader speech term or broader term referring to a motor speech impairment. Hypomania, again, one of the early and kind of hallmark symptoms that a neurologist might notice, that lack of facial expression, very flat faces or affect. Drooling, dysphagia, fatigue, very common complaint or symptom. REM sleep disorder, depression, apathy, so mood disorders, and cognitive difficulty. So a few times tonight, I'm going to be referring to some surveys that were published by the Parkinson Alliance. So the Parkinson Alliance is another non-profit organization based out of New Jersey. They are affiliated with dbs4pd.org. And twice a year, the Parkinson Alliance sends out surveys, or you can access them through their website, and then publish the findings. So this was a very recent survey, 2019, that asked about non-motor symptoms. And the items that are highlighted are the items that were noted by the participants, and this was over 1,300 people who responded to the survey, the items that they felt had the greatest impact on quality of life on a day-to-day basis. In particular, I think fatigue and cognitive difficulty, of course, should be of interest to us. I know I have patients who one day can be alert and engaged, and the next visit are falling asleep in front of my eyes. Cognitive difficulties go without saying. It may be slowness of thinking, or it may be some associated dementia or Lewy body dementia, and that's going to certainly impact patients' abilities to be able to adhere to recommendations we give them for swallowing strategies or exercise. It may increase care partner burden. So those non-motor symptoms are of importance to us as well. So the basal ganglia pathology and the dopamine deficiencies actually are relatively late manifestations of the disease. And in a minute, I'm going to talk about a model, the Brock model, which again is kind of a hypothesis of how does Parkinson's get into our body and spread into the brain. But I think, again, the interesting thing to maybe point to remember here is that when you see patients, or by the time a patient is diagnosed, because they've been sent to the neurologist by their primary care physician with some motor symptom, they've already lost about 30 to 70% of the dopamine in the substantia nigra. Dopamine is a neurotransmitter, and it's critical for the start and the stop of voluntary and involuntary movement. So we're a little bit familiar as speech pathologists, if you're working with Parkinson's patients with voice, what that dopamine deficiency, how it can kind of manifest itself. It can cause an impairment in sensory processes, or what we've learned to describe as a sensory perceptual mismatch between how loud a patient's speaking and how loud they think they are speaking, how big a movement is and how big a step really is. And so that underscaling, or that decay of movement, hypokinesia, has also been directly or indirectly implicated in respiratory, laryngeal, and orofacial movements. On a positive note, however, we know that individuals with PD often respond to external cues. So they often can speak louder, they often can move bigger. And again, that may have some implications for us when we're implementing some strategies or exercise related to swallowing function. Patients often report or observe to have bradyphenia. And I always say to patients, it doesn't mean you're thinking bad, it just means that you're thinking slower, processing information slower, having difficulty shifting motor and cognitive sets. Michelle Trochet did an interesting study where patients did a somewhat simple cognitive number repetition test during a video swallow study. And those patients that had been previously identified on neuropsych testing to have some cognitive decline performed even worse. And so it kind of begs the question, when we complete our swallowing, our instrumental swallowing evaluations, even though they are the gold standards, we nevertheless are looking at a patient one point in time. So we have to really ask, does this look in time really reflect how the patient's going to perform, behave when they're back in the dining room of the nursing facility, when they're at a restaurant with their friends, when they're home with the TV on, and now there's multiple distractions. So again, it has important implications for us when we are instructing patients, and the expectation that we might have for how well a patient is going to adhere to treatment recommendations. So in around 2003, Brock et al., a group of researchers, put forth an hypothesis that really helped us begin to recognize that Parkinson's was really much more than just a disease of the basal ganglia. It really was a multi-system disease. And one of the points of evidence for that was that the entire gastrointestinal tract is affected in patients with Parkinson's. We see that in the symptoms of drooling, dysphagia. Patients may have gastroparesis, which is delayed stomach emptying. Constipation, I think, is a very high early symptom. If you were to, again, kind of ask in a group of, at a conference, how many people have that as a problem. And loss of sense of smell, as high as 90% of people with Parkinson's would say that, yes, that was always a case. That was, again, very early premotor symptom. So this has kind of led these researchers to hypothesize that the neurodegenerative process may actually start with some type of a pathogen, some type of a neurotropic pathogen, getting into the body via two entry points, inhaled into the olfactory bulb and through the enteral system or the GI tract, as the GI tract communicates with the environment. And then the alpha-synuclein protein begins to fold in the wrong way and clump, and that protein, faulty protein, makes its way to the brain. So on the right side of the screen, you see a graphic representation of the Brock model. Again, with stage 1 being autonomic nervous system symptoms, loss of sense of smell. Patients might, even at that point, have some cardiac orthostatic hypotension, and then the pathology or the pathogen makes its way into the lower brainstem. Again, I think the takeaway here, I remember when we reviewed this article when it came out, so probably around 2003 or 2004, what the neurologist thought was just so interesting. This was really so enlightening, was that it told us that even when patients come into your practice with the onset of motor symptoms, they have already had the disease for about 6 or 7 years in other systems of the body. So alpha-synuclein is a major component of Lewy body, and you hear that term associated, of course, with Parkinson's, which constitutes the neuronal inclusions or the pathology that characterizes Parkinson's. So again, the hypothesis is that this gut protein starts folding in the wrong way, it clumps, that these aggregates get carried to the brain and then begin to spread within the brain from cell to cell via the sympathetic and the parasympathetic nervous system, so part of the autonomic nervous system, eventually to the central nervous system. Alpha-synuclein has been found in the dorsal vagal nucleus of the vagus nerve, and so again has led researchers to hypothesize that the vagus nerve, in fact, that very long cranial nerve, may be the conduit for the gut, that faulty protein to actually make its way from the gut into the brain. And that's, of course, any involvement of the vagus nerve is also of interest to us as speech-language pathologists, because we know that the vagus nerve carries sensory information to the larynx and the pharynx. It innervates muscles of the pharynx, the cricopharyngeus, and the vagus also controls muscles of the respiratory tract and of the esophageal phase of swallowing. So current models suggest that vagal control of voice and glossopharyngeal control of posterior tongue movements might be among the first manifestations of the disease. But the early changes are subtle, and so patients may be able to adapt and may be able to compensate. You're going to hear me, I'm going to talk in a moment about, again, Parkinson Alliance survey about patients' report of swallowing problems, and it's typically very, very low or very poor. But if you think about it, we all have probably had some experience of symptoms or a symptom that we either ignored or we just didn't put 2 and 2 together. We didn't realize it was something we should be paying attention to, that it might represent some other problem. In postmortem studies, researchers have found Lewy-type pathology in the pharyngeal sensory nerves of patients with Parkinson's. So if the pharyngeal sensory nerves are damaged, then that could certainly be why we often see decreased pharyngeal sensation, silent aspiration, problems with airway protection or airway reflexes, all contributing to oral pharyngeal dysphagia and aspiration or silent aspiration. And then finally, I would just add into that mix, and I'm going to be talking a little bit later about some of the other movement problems that can be associated with Parkinson's, the dyskinesias or dystonias, movement problems that can occur in response to the medications or during on or off periods of medication that can also impact swallowing function. So it's complicated, that's for sure. In the handout that Ed mentioned, and it's just the key points from tonight, that was something I created a couple of years ago when I spoke at a Parkinson's support group and used the acronym Parkinson's. I thought that might be an easy way to remember what some of the key points are. So throughout the presentation tonight and some of the slides, you'll see that represented. So here was the first P of the Parkinson's, and that is that people with Parkinson's often underreport swallowing problems. Some studies indicate that less than 10% of people with Parkinson's actually reports swallowing problems despite symptoms. 86% of people with drooling have oral pharyngeal dysphagia, and daytime drooling is associated with silent aspiration. I see a lot of people that as a complaint, but I think it's interesting that even patients who have already gotten Botox injections as a way of reducing the drooling have not been referred for a swallowing study. So even their neurologists are not perhaps making that connection or seeing that connection. So in 2017, the Parkinson Alliance conducted a survey about swallowing, and among their results, they asked the question, how concerned are you about swallowing? As you can see, 10% were quite a bit, but the majority of them, 31%, 35%, a little bit, about half of the respondents, 31% of the 67% who reported a problem said that other people, probably their spouse, had concerns about swallowing. And I hear that, I'm sure you do in your practice, where the patient will say, no, I don't have any problems, and the spouse is nodding their head that they're coughing or choking during a meal. The graphic is interesting because that's representing patients' own report of severity of swallowing difficulty. It might be a surprise to you that only 3% were reporting severe swallowing problems, because we often think of them, patients with PD, as having fairly severe swallowing problems. But again, I'll just propose a couple of thoughts here. One, we may not be asking the right questions, right? We may not be probing in the right way. I would assume that most of the respondents to the Parkinson Alliance survey are probably patients living at home in the community, so maybe relatively unimpaired from that standpoint, not patients in nursing facilities or extended care facilities, so in later stage of disease. But I also think it's that patients just don't realize it. And this year, for whatever reason, I've had an incredible number of patients with Parkinson's walk into my office. They're taking cycling classes and boxing and doing all other kinds of things. So these are not wheelchair bound, terribly impaired people, and their swallowing studies are horrible. So again, it kind of goes back to that, not that perhaps sensory mismatch, perceptual mismatch of just not noticing it, feeling it, not recognizing that there's something going on. And then again, you see here a study where they actually looked at, compared patients' own report of a swallowing problem. Estimates were about 35%. And then when they actually completed a video swallow study on them, the actual oral pharyngeal dysphagia was as high as 82%. So just to summarize this portion, I know I'm talking fast, but I got a lot of information I want to try to get through tonight. The incidence of swallowing problems we know is pretty high, about 80%. So if you are someone here listening tonight who has Parkinson's, you've never been for a swallowing study, ask your neurologist if you can see a speech pathologist, even if it just is a baseline study you will be ahead of the game rather than waiting until you have symptoms. Because we know that swallowing difficulties or dysfunction is present in the very early stages of the disease. So I say act as if, and put yourself in a position to be very proactive. The origin of swallowing problems are probably multifactorial, having to do with some dopamine deficiency, but also some pathology outside of the dopaminergic system. Dysphagia tends to be overlooked until swallowing difficulties reach an advanced age, and patients may underreport symptoms and physicians may underrefer. I remember years ago with voice where the estimates were horribly low, 8% or something of patients that got referred for speech treatment. I don't know because I haven't really seen similar statistics for swallowing, but I'm going to hazard to guess that they're also kind of dismally low. So the little guy on the bottom, that little cat burglar, I've used him for years in my PowerPoints when speaking with persons with Parkinson's, because to me, he really characterizes the disease. It's a sneaky disease, it's insidious. It's like some malware that's gotten into your computer every now and then. It acts a little goofy, but you kind of ignore it until you can't ignore it anymore. So that's always what I tell people and patients, and particularly when we begin some type of an exercise program. You've got to keep going because this disease is over here in the background, changing the way muscles are working. All right, so this is our first movement break. Let's see here. Elizabeth, can I put my webcam? Let's see if I can join you here. Oh, I guess my webcam is up, huh? I just don't see myself. All right. So here's our first movement. So as you inhale, you're going to clasp your hands together. As you inhale, your arms are going to come up chest level. You're going to exhale through rounded lips as you rotate to the side, hold that stretch, and then you're going to rotate back to the center. You're going to vocalize and ah. And then when you're back to the center, you're going to open up into a nice big stretch. Just inhale, exhale, and release your arms. All right, let's do it to the other side. So arms come up chest level as you inhale, exhale to the side, rotate to the side, hold the stretch. It shouldn't hurt. Go as far as you can. And then you're going to vocalize with an ah as you come back to the center. Ah. Open your arms into a big stretch. Release your arms. And let's see, do we have any questions? Nope. If not, I will just keep going. All right. All right, so I'm going to now talk and show you some videos of some video swallow studies of patients. This is not a webinar on normal swallowing, and there are many webinars and resources, excellent resources for that type of information. But normal is always the reference point, so we will start there tonight. We typically kind of talk about the stages or the phases of swallowing, even though we know that it's a very highly synchronistic event, that movements are sort of happening simultaneously, not this happens and this happens and this happens. But I nevertheless think it's an easy way to explain and to understand, particularly when I'm talking with people with Parkinson's who have never seen a video swallow study. I think of it in this way, kind of like a dance. And when you break down a dance into the steps, then you put it back together again with the music. So if swallowing were a dance, I think of it as a quick step. It's got to move really well timed, really quick, in a really highly synchronized fashion. So the lovely image on the bottom, the little still animation, is from about a 9-minute animated video it's available on YouTube, narrated by Dr. Bonnie Martin Harris. It's from her MBS IMP course. It's a wonderful video of a normal swallow. So I would really invite you to go look at that, regardless of who you are. If you really have an interest and would like to see the normal swallow, or if you're, again, someone listening tonight who has Parkinson's, or you're a care partner, or you run a support group, it might be a great video to share with your members to help them understand what constitutes a normal swallow. But for tonight, we'll just use it. Elizabeth, do I have a pointer anywhere?
Yeah, we can see your arrow, your mouse.
Oh, you can't see my arrow? Oh, I'm moving it all over the screen. Okay, now you tell me. All right, so here are the lips. Here's the oral cavity. It already has a bolus in here. Here's the hard palate, soft palate that prevents food or liquid from going into the nose. I always like the notion of thinking about the upper aerodigestive tract as a series of valves that are either permitting or preventing food or liquid from going in one direction or the other. This is the big bulk of tongue. This is the base of tongue where food, you're going to see in a few patients, likes to get stalled or connected if tongue motion is not strong, if base of tongue is not strong. This is the epiglottis cartilage that tips down during the swallow. The hyoid bone, so there are some anatomic markers that speech pathologists look for, which is hyoid laryngeal elevation or movement that helps to provide airway protection. It helps to open the PES segment or the opening to the esophagus. We have the posterior pharynx and then heading into the esophagus. Whoops, and here's the vertebra. So you're going to see now just a normal swallow, very quick, patient drinking a thin liquid. But again, mostly what to pay attention to, particularly if you're someone listening tonight who is not a speech pathologist, is just the speed and the fluency of the swallow. So here we see the epiglottis, base of tongue, patient's jaw. Everything goes down cohesively, nothing gets stalled anywhere. And remember, always when we're swallowing, we have a cessation in breathing, so perfectly timed breathing and swallowing. All right. So I often show that to patients now ahead of showing them their own video swallows, or they'll often ask me, because when we begin to look at their swallow studies, even to the untrained eye, patients can often tell that there's something that does not look right. So I'm not going to go through all of these points because you'll see them again as we look at a few of the videos. But it certainly just represents all of the potential breakdown that there can be in any discrete or distinct phase of swallowing, but again, always that relationship of the parts. So what's happening in the oral phase is going to affect the pharyngeal phase and so on. I don't have video tonight of going through the esophageal phase of swallowing, but again, I do just want to mention that esophageal dysmotility, reflux problems are very common in patients with Parkinson's. Gastroparesis, which is delayed stomach emptying, can be a very big problem for patients. They'll get full very quickly. And a reduced opening or relaxation of upper esophageal sphincter, also referred to as the pharyngeal esophageal segment, also very common. So I'm going to show you three very brief little video clips of patients. But ahead of these, I'll just ask you a question. It's just for kind of for you to be thinking about. So these are three patients. These are three patients of mine. They come into your office for your first evaluation. They bring a presenting complaint. You're going to take a little bit of a history, and then we see the swallow study. I'm going to ask you, as you look at these three patients, if you could predict or project which of them might be the person who has had recurrent aspiration pneumonia. One of them has. But when we look at some of the problems that we associate with the oral and oral preparatory phase of swallowing as it pertains to Parkinson's, we've already said 90% of people with PD have no sense of smell. So certainly, although again, haven't seen a lot of literature that specifically addresses that, other than to concur that that could impact that preparatory phase of swallowing. and maybe impact from a sensory standpoint. Patients have a movement disorder, so they may have a predominant tremor as their primary motor symptom. They may have dyskinesia, again, particularly related to levodopa, and both may be unpredictable as to when they may be better or worse, and may impact self-feeding. They may impact the ability to accurately grade the amount of food that they get on their spoon or their fork. Lingual pumping is often seen and described as a pretty common problem that we see in Parkinson's patients. I see it as a oral motor symptom very similar to what we see in gross motor, of trying to, patient gets up from a chair and can't quite get started, can't get their feet are stuck to the floor is what they'll often tell you, or they get started and then they have these fascinating movements. So again, that lingual pumping to me always feels kind of like a similar type of problem. A slowness in chewing, so again, bradykinesia, hypokinesia, muscles that are stiff are slow. They don't move real quick. They don't move real fluidly. Poor lip seal, if a patient tells you during the interview that they drool or you see them drooling, then you know that's going to potentially be a problem for them when they're eating. And piecemeal deglutition, just not being able to, for the tongue to be able to hold material cohesively and propel it cohesively into the pharynx. So this is a 96-year-old patient. She's been a patient of mine for a number of years. She came back to me this year. She's had a Parkinson's diagnosis for 6 years. She lives with her daughter. She ambulates with a walker. She's a lovely lady. But she and her daughter reported some new onset of difficulty with chewing, increased coughing with liquids, and some concerns for aspiration. And at this point in the study, we had already progressed to a soft solid. So you see here, again, the base of tongue and the vallecula. She's already got some residue in there from some prior swallow or swallows. And already you can begin to see that chewing is a bit laborious, right? A lot of movement that's not getting anywhere. The other day when I was watching this, I timed it. I think the first swallow happened in about 8 seconds. I think the next one happens in about 12 or 13 seconds. And so already I think, can you imagine if every bolus, every bite of food takes 15 seconds to chew, to manipulate, to keep it onto the tongue, to keep it from falling into the sulcus or beneath the tongue, how tiring, how fatiguing swallowing might become. What an endurance task it might be to have to keep coordinating breathing and swallowing. So finally another swallow, and now a little bit more retention of material in the vallecula. We move now into the pharynx, again recognizing that we're talking about a system, so the oral pharynx, but pharyngeal stage or phase problems, again with our PD patients, impaired sensation, muscular rigidity. Again, remember this is a disease that's from a motor standpoint characterized as slowness and stiffness of movement. So any slowness and stiffness of movement is just going to change the timing of the swallow, the timing of the transfer, the timing of breathing and swallowing. Reduced peristalsis, so muscles just not squeezing hard and pushing material through the throat or through the pharynx sufficiently. Reduced laryngeal elevation, a delayed swallow initiation. Remember, we talked about pharyngeal sensory impairment due to Lewy body in those nerves. You've already seen retention of material in the vallecula, and again, problems with material getting into the esophagus due either to some problems with opening or relaxation. And then obviously penetration or aspiration, if it happens at this point of the swallow due to some mistimed swallow and problem with airway protection. So our next patient is kind of an interesting guy. He's a 72-year-old male, came with a diagnosis of Parkinson's about 3 years, but some interesting comorbidities. He had an anterior cervical fusion in 2000. You can see the plate here in his neck, and you'll see it again on the video. And then in 2014, he had a malignant facial lymph node removed on the right side of his face with sacrifice of the facial nerve, followed by chemoradiation. So he has very flaccid on the right side of his face, complains of too much saliva, really sticky saliva. Here is his swallow. So here again, for a very different reason, we see this little kind of chipmunk chewing, being able to try to manipulate, keep the food, in his case, out of that very flaccid side. So at this point in the study, again, we run a soft solid bolus. So you heard probably the instruction to do a chin tuck to see what effect that had on the swallow. You see he already has some residue in the vallecula from some prior consistency. And obviously not a very efficient swallow. You see residue here coming over the base of his tongue on the posterior pharyngeal wall. And again, what's interesting is he's not really sensing that huge amount of residue. So when you see patients entrapping a large amount of residue in the vallecula or anywhere in the hypopharynx, and they're not reacting to it, that tells you about the deficient sensory information that they're getting, and also would make you not be surprised that these aren't patients who are reporting swallowing problems. They're not feeling them, they're not sensing them, not at that level anyways. So aspiration, again, kind of a scary word. I think that patients with Parkinson's read about or hear about or are threatened with by some therapist if you don't do this or that. So aspiration of saliva, food, or liquid basically occurs when the last line of defense, the vocal folds, fail to protect the airway. It's often the result of an impaired swallow, but we know that aspiration can occur with food or liquid entering the airway from above or from reflux material entering the airway from below. In either way, it often is occurring because patients have an ineffective cough reflex. They're not reacting to the aspirated material, or if they do react to it, they have an inefficient cough to clear the airway. So we know that aspiration should cause coughing, but when it doesn't, it's silent aspiration. And again, it points to the sensory deficits in the larynx. I always think the easiest way to think about aspiration is that it always indicates a mistimed swallow because we can only breathe or swallow, we can't do them both. And aspiration of small amounts of oral pharyngeal secretions we know are normal in healthy persons during sleep, yet aspiration of microorganisms from the mouth can also be pathogens can also be a source of pneumonias. Aspiration pneumonia is an opportunistic infection. It has to have the right set of circumstances to occur. So it's a pneumonia or an infection that's caused by specific microorganisms. And degenerative diseases of any sort, including Parkinson's, where there's reduced cough clearance, increase the risk of aspiration pneumonia risk. We also know that there are normal aging processes that are going on. So when we are talking about our patients with Parkinson's, many of them are going to be older adults, so who may have some age-related factors that also need to be considered, and just their functional reserves may be less because of that. I already mentioned about microaspiration of oral secretions. Colonized with bacteria can be a contributor to aspiration pneumonia, and tube feedings, of course, aspirated can be. I think a sad statistic is that aspiration pneumonia remains a leading cause of hospitalization and a leading cause of death in persons with Parkinson's. But the important takeaway is that it's also often preventable. And that's really, I think, where we need to focus as speech-language pathologists. Again, early referral, early identification, early strategies. And individuals with PD should be asking for those early swallowing referrals so that they stay ahead of any of these problems. So the next patient, the last patient we'll see, is an 84-year-old male. He's had a diagnosis of Parkinson's for 3 years, was recently hospitalized in March with onset of confusion, coughing up blood, and a diagnosis of aspiration pneumonia. He is at this point in the study getting a nectar liquid, and again being asked to do a chin tuck to assess the effect that has on swallowing and airway protection. So here we go. So I'm going to play it just real quickly one more time in case you didn't catch it. I'll try to put my pointer there. He does aspirate. And then again, I don't know how well you can hear the audio, but when he's cued to cough, he has a really pretty weak cough. So again, the aspiration didn't trigger a cough, so silent aspiration, he coughed when he was cued to. So again, aspiration pneumonia, an opportunistic infection, it really requires the elements to create the perfect storm. Something has to be aspirated, the aspirated material has to contain pathogens, the aspirated material has to be able to overwhelm the normal defense mechanism. And the patient's own immune system. And so we know that there's multiple factors that, including a swallowing problem, that put people at risk. And what might some of those be? Patients that are elderly, sick from something else, immobile, bedridden, weak, or have a weak or ineffective cough, dependence on others for oral hygiene, Parkinson's patients who are in late stage disease, so maybe wheelchair bound, fairly immobile, very weak cough, Parkinson's patients with dementia or Lewy body dementia. And frankly, I think a hospital admission for any of our patients, but particularly individuals with Parkinson's, where the timing of medication may be off, they may have an unexpected surgical procedure with anesthesia, several days of immobility, and that can really be the trip down the slippery slope for people. So if you think back to the patients that we just saw, those 3 individuals, you know, I would ask how well can we predict based on the history and the clinical exam alone, who might develop an aspiration pneumonia or a recurrent aspiration pneumonia? Is advanced age the predictor? Are the comorbidities the predictor? Is it the patient where we saw some trace aspiration on the video swallow study? Is the presence of cough or weak cough a predictor, or is it adherence to treatment recommendations? We don't have time to get into discussion tonight. I would say probably all of those are predictors. In our 3 patients, or my 3 patients, it's actually the last patient who's the patient that's had recurrent pneumonia 4 times, as a matter of fact, since 2016. All right, quick movement break, but actually you can be stretching, and I'll just ask if there's any questions. So you're going to put your foot on your heel. You're going to reach down for it as you inhale and exhale. You're going to hold that stretch, inhale and exhale back up, and you can switch to the other side while I ask Elizabeth, do we have any questions? And if not, I'll keep going.
We do have a couple of questions. I'm going to let Ed jump on here, and he will ask you those.
All right.
So Mary,
Yes.
Here's a question from Helen. Considering the head-to-brain connection now confirmed, is there any research or guidelines around specific diets with a food-based medicine approach for PD?
Yeah, so I think I've actually recommended this neuropsychologist to Elizabeth to do a webinar. There's a neuropsychologist down at Fort Myers, Mabel Lopez, who did a wonderful, I've heard her twice now, do a wonderful presentation on that gut-brain relationship, actually, and talk about specific dietary considerations. As I move a little bit along, I'll talk just a little bit when I talk about dopamine absorption, a few issues related to medication absorption that are specific to Parkinson's. Yeah, there's a growing body of literature just in general, outside of even Parkinson's, that talk about gut-brain relationship. In fact, patients with Crohn's disease are noted to have a higher incidence of Parkinson's. And again, with the thought that the relationship is, again, some gut microbes. Another question, Ed?
Yes. Do you ever recommend a chin tuck without observing the effect on video?
I don't.
Residue in the piriform sinus can spill during a chin tuck.
I don't, because I've witnessed too many times through the years that you cannot predict. Sometimes a chin tuck improves the pharyngeal swallow. Sometimes, as you saw with that patient, where they didn't aspirate, they aspirate. For whatever reason, I think it is one of the compensatory postural compensations that the physicians all have latched onto, and I often see that written, or patients will tell me, oh, my doctor told me I should just tuck my chin. But I personally would never recommend it unless I had documented that it was really being of benefit.
Okay.
Right.
One more question, and then I'll turn it back over to you. What is the incidence of aspiration pneumonia versus pneumonia in Parkinson's disease patients?
I don't know. I'm guessing it's probably not too much different than maybe in other groups where there are community-acquired pneumonias, during pneumonia season when people get pneumonia versus aspiration pneumonia. But I don't know. I don't think I can answer that tonight.
Okay, thank you.
All right.
There are others, but we'll come back at the end.
Okay, yeah. I'm going to try to rush along here because I'm looking at my watch and I know there's a lot to come yet. Okay, so I'm going to move ahead. All right, so I'm going to talk a little bit about dopamine effect on swallowing, the replacement dopamine, DBS, and breathing swallowing coordination. So not all patients at the time of their diagnosis, all persons at the time of their diagnosis will be prescribed carbidopa, levodopa. Some younger patients might get an agonist drug, some patients get anticholinergics, but sooner or later, all patients with Parkinson's will get carbidopa, levodopa. So that's just what I'm going to comment on tonight. And levodopa is the dopamine that we're trying to replace into the brain, but if it were given on its own, it would be broken down by other enzymes. So it's given with a carrier, which is carbidopa. And recently, again, in an article we reviewed at our journal club recently, there was a very large review that was done and published in Movement Disorders, concluding that levodopa, so carbidopa, levodopa, remains the best drug for symptomatic treatment of Parkinson's. But the question as to whether or not or how beneficial it is to speech or swallowing is really, there's no conclusion there. So controversy exists as to whether or not dopamine replacement actually yields any benefit or improvement in swallowing symptoms. Some report some benefit. Others have reported that actually, particularly over long-term use, it might actually begin to inhibit some of the brainstem reflexes, so actually further impair swallow. And we've already said that it's very likely that the swallowing problems in Parkinson's are related to pathology in brain regions outside of the basal ganglia. And so that may be another reason why patients are swallowing is less responsive to dopamine. Another theory is that by the time patients develop motor symptoms, remember we said now that they're already mid-stage disease, they've had the disease covertly for maybe 6 or 7 years, that the limbs take up much of the dopamine and there's not enough left over for the swallowing or motor speech system. So those are kind of theories, but if dopamine, where it has been shown or when it has been shown to be of benefit, appears to be on the oral stage, so the voluntary stage of swallowing, with some reduction of rigidity and bradykinesia. Keep in mind that patients with Parkinson's also have respiratory muscle weakness, inspiratory and expiratory, and so that can impact the timing of breathing and swallowing. That again is not related to dopaminergic function or dysfunction. And then I think that most neurologists would probably advise patients that it's really the timing of medication that's the most important factor, even more important than the delivery system. So carbidopa now is available in oral form, some long release, a dual pump, which is a gel through a J tube. There's an inhaled version. I don't know if it's available yet in the US, but soon it will be. So those are all just the delivery systems. But really what's really important as therapists to really emphasize with patients is the importance of the timing of their medication. I never used to always ask patients, well, when was your last dose? But every visit now, whether I'm seeing them for speech or swallowing, I ask them, when was your last dose of medication? Because if they're sitting in front of me having wild dyskinesias, I want to be able to document for them, for their physician, if that's a medication affect movement disorder that is confounding what I'm trying to do and making it more challenging for the patient. Again, Parkinson Alliance survey. When they do their surveys, one of the nice things is they separate out individuals with DBS and Parkinson's patients without DBS. And here's the graphic that you saw earlier in terms of patients' own report of swallowing difficulty. Interestingly, of the 67% of the patients who reported swallowing problems, only 34% of them had actually had a swallowing evaluation. And based on their survey, they make the point that it's really the disease duration that may be more of a factor than the patient's chronological age. Because remember, young onset patients, you may be seeing them in their 60s, but if they've had the disease diagnosis since 40, they've already had it for 20 years and have already been on medications for 20 years. In a survey that the Parkinson Alliance did in 2014, where they were specifically looking at autonomic symptoms, non-motor symptoms, there was a statistically significant difference between DBS patients, deep brain stimulation group, and the non-DBS group, with the DBS group reporting more swallowing difficulties. There was a statistically significant difference between the placement of the leads. So there are 2 points of where the leads are placed. So deep brain stimulation is like a pacemaker for the brain. You could kind of think of it that way. And so the leads are placed either into the subthalamic nucleus or the globus pallidus. Those are the targets. And the patients with lead placement in the subthalamic nucleus reported more swallowing difficulties. And as some of the research has emerged with regards to speech difficulties following DBS, you see that same finding. And again, with or without DBS, the longer the patient is living with the disease, the more likely they're going to have swallowing problems. If we look to the research, we can look to Michelle Troche, who's continues to do some great work looking specifically at DBS effect on swallowing. In 2003, she did a review and concluded that there was no clinically significant improvement or decline in swallowing. Other researchers have published reports where particular parameters were improved, so they might have seen an improvement or reported an improvement in tongue strength or some component of the pharyngeal swallow, but it's hard to conclude as to whether or not those individual gains actually equate with improved overall swallowing safety or improved health outcomes. DBS with subthalamic nucleus placement, particularly bilateral, because DBS can be right or left or both, has also been associated with dyspnea, shortness of breath, and vocal fold dysfunction, and that can often present itself as like a laryngeal dystonia. Again, in a couple of articles from Michelle Troche, where she indicates that now with the awareness of some of these speech and swallowing problems related to lead placement is becoming really a new focus for investigators in this area to really see if they can identify different targets or stimulation parameters, because once the leads are placed into the brain, then the DBS has to be programmed. And the goal is to try to give the patient good motor function or a reduction in dyskinesias, and at the same time minimize the impact on motor speech or swallowing. So dyskinesias and dystonias are, I'll say, kind of associated movements that are pretty common that you will also see in your patients. So again, we think of Parkinson's characterized as slowness, stiffness of movement, but the longer patients are on carbidopa, sooner or later, probably most or many patients will develop dyskinesias. We've probably all seen Michael J. Fox. You can think of him as having some dyskinesia, so there's sort of chorionic movements, kind of squiggly movements. They're motor fluctuations, and they occur later in the disease as the window of time of the medication being effective in the body begins to shorten. Carbidopa will always be effective. The problem is the patient is losing dopaminergic neurons, and so they're producing less of their own dopamine. The motor fluctuations can also be caused by gastroparesis or medication absorption. That can also be affected by meals, particularly high protein meals, which compete for the transmission of dopamine across the blood-brain barrier. Dyskinesias can affect any part of the body. So you sometimes see patients with oral mandibular dyskinesia. Patients can have trunk dyskinesias. Toes can curl up. A very specific kind of dyskinesia is tardive dyskinesia, where patients are sticking out their tongue or maybe making lip smacking noises. Tardive dyskinesia has historically been usually associated with either psychotropic medications, thorazine, some antidepressants, the antiemetics, compazine, so medications given for nausea. And so kind of a dilemma for psychiatrists has sometimes been that if they treat patients with antidepressants, that they run the risk of perhaps developing a tardive dyskinesia. You hear it on the commercials on TV, actually. They don't say tardive dyskinesia, but a movement problem. And up until recently, there has been nothing to address tardive dyskinesia. There are now a couple of medications I have listed there. And actually with dyskinesia as well, there has up until recently been no medication that could improve or resolve patients' dyskinesias. It's actually one of the indications for deep brain stimulation. And now Gocovri is a new drug that is actually indicated for managing dyskinesia, drug-related dyskinesias in persons with Parkinson's. And then interestingly, respiratory dyskinesias, again, we're seeing patients clothed, so we might not necessarily be able to see that their trunk muscles are squiggling or not moving, and they're moving in sort of an irregular pattern, but we certainly may hear it in voicing patterns, or again, it may be impacting the timing of breathing and swallowing. And it can often be perceived by patients as anxiety. And we know that anxiety and breathing, that relationship, even in non-Parkinson's patients, can be kind of a vicious cycle. Patients can also have dystonias. We're familiar as speech language pathologists with spasmodic dysphonia as a focal dystonia. If you think of dystonias as a muscle cramp or a spasm, again, in individuals with Parkinson's, it can be almost anywhere in their body, including a laryngeal dystonia. Cervical dystonia occurs in about 60% of people with Parkinson's. And again, obviously, if it's affecting the neck or trunk muscles, can affect voice and swallowing. In the literature, you'll see a number of reports that on video swallow studies, patients with cervical dystonia also have a higher incidence of dysphagia and also are often underreported. And the mainstay treatment there is botulinum toxin injections, A or B. And while they are effective in reducing the dystonias, a common or possible adverse effect can be some spread of the Botox into pharyngeal muscles, affecting the swallowing. Dystonia, when we think of it as a spasmodic dysphonia, fortunately is not painful, but dystonia in other parts of the body can actually be quite painful. Breathing and swallowing, I think this quote by Andrew Wild sort of says it all, right? We know that breathing and swallowing share a common pathway, and so that precise coordination is vital for airway protection. We know that respiration is inhibited before and during the pharyngeal swallow. And neurodegeneration of the substantia nigra, which is really the hallmark of PD, is accompanied by extensive loss of neurons in sites outside of the basal ganglia, including the brainstem nuclei, which are involved in the physiology of sleep and respiratory control. This quote by Douglas Adam I thought was a great quote, my insertion of swallowing. But again, as much as we know about breathing, swallowing coordination, it's a lot more complicated. I think if we just start from the position that it's all very complicated. But respiration and swallowing coordination may be compromised in persons with Parkinson's. Again, we're always breathing or swallowing. Dr. Bonnie Martin Harris and others have identified sort of the optimal pattern of timing of breathing and swallowing in healthy adults, and exhalation before or exhalation before and after the swallow is reported to be the most consistent and common respiratory phase pattern. But even in healthy adults, that may be volume dependent or consistency dependent. We know that the timing and the coordination of breathing and swallowing is key to protecting the lower airways, and that high incidence of oropharyngeal dysphagia that we see in our Parkinson's patients may very well be have a high association with impaired coordination of breathing and swallowing. And again, easy way to think of aspiration is just a mistimed swallow. We use the muscles of exhalation for effective cough. And so bradykinesia, stiffness of the muscles around the rib cage, changes in posture, all can affect cough strength and cough efficiency. So inspiratory muscle weakness, particularly the diaphragm, has been reported in very early stage Parkinson's, and early sleep disorders are thought to be some of the first clinical expressions of diaphragm dysfunction. Several studies suggest that respiratory muscle strength may again be unrelated to dopaminergic function, so not expected to get better in response to carbidopa. And impaired pulmonary function may really be due to extrinsic causes. Again, poor posture, restricted chest and abdominal movements due to stiff muscles, rigidity in the chest wall, poor compliance, and disrupted respiratory coordination. I already mentioned levodopa-induced dyskinesia. So again, if patients are having dyskinesia or dyspnea as a wearing off effect of their medication, that may also affect breathing, swallowing patterns. And exercising the diaphragm, whether we're doing range of motion exercises or strengthening exercises, may help not only with core strength, but may be a tool for helping patients reestablish a more normal pattern of breathing, swallowing. Expiratory muscle weakness and swallowing has probably been more investigated, and particularly cough, because we know that cough is essential. It's an essential airway protective mechanism, both reflexive and voluntary, but it's what protects the upper and lower airways from a foreign body. And weak expiratory muscles, which are the cough muscles, affect effectiveness and certainly are a high contributor to, again, who might be at risk for the development of an aspiration pneumonia. And with the progression of PD and worsening of motor symptoms, of course, that impaired cough reflex is just going to increase the aspiration risk. So again, you know, what do I tell individuals with Parkinson's? Any of you who are listening tonight, important to know your body and to report symptoms. What might those be? Obviously, repeated upper respiratory infections, shortness of breath that you might experience during or after swallowing, coughing or throat clearing during or after meals, if you're expectorating food particles during or after a meal, drooling, poor management of saliva, weight loss, a wet or gurgling voice that represents material that's again puddling above the airway, or meal times that are just taking longer. If you think of the very first video that we saw of the 96-year-old taking 12 seconds to be able to manipulate and transfer a bolus. Obviously, nutrition is important for all of us. But just a couple of things I'll say here relative to Parkinson's. So carbidopa is absorbed in the small intestine, and once there, it may compete for gut-brain absorption and blood-brain absorption. So patients are sort of cautioned against eating a very heavy fat or heavy protein meal that can compete for that dopamine absorption. And obviously, dysphagia can impact in many ways. And Michael J. Fox just released a really nice guide, Parkinson's Disease and Diet, a practical guide, and I would encourage you, whether a therapist or an individual with PD, to maybe get that. I'm kind of moving fast because I'm seeing the time and have more slides. Okay. So again, we've already concluded patients may not be real reliable informants, so just asking, do you have a swallowing problem, may not be enough. The Movement Disorders Task Force, in evaluating dysautonomia rating scales, made a recommendation of a few that are starred here, the Siluria Swallowing Clinical Scale for PD, Swallowing Disturbance Questionnaire, and Swallowing Quality of Life Measure. I add to that list E10 screening tool, which I think a lot of us are familiar with in youths, the Yale Swallow protocol. And then while not a scale, I don't doubt that out of their research is going to come some type of a scale or assessment tool, and that's looking at a patient's voluntary and sequential cough as an indicator of airway protective status. We have already mentioned that none of us has X-ray vision, so how necessary an instrumental swallowing assessment is. So most often what you see in the literature is what's suggested for patients are strategies that might improve swallowing function, changes in head posture, swallow hard, alternating liquids and swallow, teaching or instructing patients in breathing, swallowing coordination patterns. We might consult with our OT colleagues for utensils that might minimize tremor or dyskinesia effect on self-feeding. And we know that while thickened liquids have a role in providing some better control of liquids, if aspirated, thicker is not always better. Swallowing exercises, again, that could be a whole webinar, and that's not the intent of tonight's webinar. But just a few things that I'll say here, and then I just have a few examples of some exercises or approaches that were reported with persons with Parkinson's. Dr. Laurie Burkhead Morgan, back in 2007, along with Dr. Jay Rosenbeck, wrote a great article that began to really focus our attention as speech-language pathologists on the role of exercise in dysphagia management, drawing from what we understand about exercise of skeletal muscles. And one of the principles in exercise that applies to our body and to swallowing is that we need to pair the exercise with the intended goal. That's specificity, right? So the exercise device, I'll say, or the exercise that has sort of taken the speech pathology world by storm is the EMST device. EMST stands for expiratory muscle strength training. The patient on the top right is using an EMST. So it is a handheld respiratory muscle trainer designed to focus on strengthening of the expiratory muscles. So those are the cough muscles. The research supports what we would expect to be the beneficial outcome, and that is improvement in cough strength. And we know that improvement in cough strength reduces the risk of aspiration or other pulmonary sequelae. In addition, EMST use with Parkinson's patients has also been shown to improve hyolaryngeal elevation or submental muscle strength, also providing airway protection. Strength is not the only problem for patients, right? They also have, we know, hypokinesia. So again, it's under scaling of muscles. They have rigidity of muscles. So some retraining of movement patterns may also be of benefit. So the Wang study was reported in movement disorders, and it was kind of interesting, a 12-week study where they instructed patients in oral lingual exercise, coupling it with an effortful swallow, and demonstrated improvements in control and coordination of the bolus. Neuromuscular electrical stimulation, we know has, again, mixed reviews in the literature, including with persons with Parkinson's, but this was a study completed in 2018 where they combined NMES with an effortful swallow and demonstrated some improved hyolaryngeal elevation and reduced aspiration. SEMG biofeedback is not necessarily an exercise tool, but it is a feedback tool. And so it begins to sort of fit in with a skills-based training approach that's now being discussed and seen as being as important as exercise and strength training. And then Lee Silverman voice treatment. So in a small study with a small number of patients in 2002, LSVT treatment was shown to generalize with what they described as a crossover benefit to swallowing. And then in a more recent pilot study where they looked more specifically at some respiratory parameters, the study investigators reported, again, a spread effect on swallowing function and involuntary cough in patients with mild Parkinson's, I'll say early disease Parkinson's. So, you know, when I talk with patients about that, it doesn't mean that voice therapy is a substitute for swallowing therapy, but they certainly can have a synergistic effect in that shared system. It makes sense that one might support or yield some improvements in the other. But nothing works for every patient. Again, I think just as medications with this population need to be really individualized to the patient's symptoms, same is true with swallowing treatment. We really need to tailor it to the patient's symptoms, to their learning needs, to the level of supervision required. Early on tonight, talked about how patients have difficulty with shifting cognitive sets or dual tasking. So we really need to start our treatment with an eye towards where the patient is at, what skills they're going to need to learn. I always have felt strongly that the first time I see a patient, that should be the day I begin discharge planning. And a part of that discharge planning is that I need to be probing and understanding what that patient is able and willing to do, or is that then going to be a burden to the care partner if they're going to have to be coaching and reminding. VAST, video-assisted swallowing treatment, is an interesting approach that's been reported using video from FEES studies as a way of combining that with exercise, swallowing exercise as a way of helping patients work both on the skill and, I guess you could say, and the strength of the swallow. The patient on the right is one of the first patients I ever videotaped doing swallow study because despite his cooperation and motivation, he literally instruction in the session. I videotaped him doing the exercise, employing the strategies. I put it on his desktops and he loved it. And so it increased his adherence, it reduced care partner responsibility of having to, again, be always reminding and coaching. And it really begins more of that, again, skills approach. So we're trying to kind of break down what's got to ultimately get put back together in a mealtime situation. I can't end this webinar tonight without commenting on drooling because I know it's one of the main complaints I hear from patients. So saliva is produced in the submandibular, parotid, and sublingual glands. At least those are the primary areas. And stimulation of the salivary glands is a part of the parasympathetic system, and we've already noted that patients have autonomic nervous system impairment. Saliva is important for dental health, for taste, for mastication, for bolus formation. So I always remind patients too much or too little, neither is a good situation. And drooling and sialorrhea actually are used interchangeably. They are defined a little bit differently, but basically sialorrhea is excessive saliva beyond the lip margin, due either to an increased production of saliva or a failure of the mechanism to clear and remove saliva. And likely with Parkinson's, it is a combination of those two things. But medication may also cause a drying effect or can change the viscosity of secretion, so patients may complain about that. Interesting alpha-synuclein pathology has been found in the submandibular glands in nearly all Parkinson's patients, again pointing to that involvement of the parasympathetic system. And so while sialorrhea or drooling is probably related to the dysautonomia, it is just confounded by postural changes, poor lip seal, decreased sensation and hyponemia, and poor awareness of drooling. Regardless of the reason for it, most patients that I see at least find it very distressing or embarrassing. So what can be done about it? There is some evidence that chewing gum can be a simple strategy. I think it's a simple behavioral strategy that patients can try to control drooling. It will increase the rate of saliva, but also the flow of saliva, but also the rate of swallowing. For many years, I've suggested to patients that they use a wristband, like a tennis player might use. One, it's more hygienic than laying soggy tissues and hankies on surfaces, but it can also serve as a cue. So I'll tell patients that when they go to reach their arm up to wipe their mouth, why not just do a hard swallow, get their lips together, and use it as a cue to swallow, because we know patients respond to external cues. Anticholinergic medications, atropine sublingual drops is an example. Those are actually eye drops, but a side effect is a drying anticholinergic effect. May be prescribed for patients, but they're usually recommended with caution for older patients because they have been associated with memory loss. And then again, probably the mainstay medical treatment is going to be botulinum toxin A or B. It's injected into the parotid and/or submandibular glands, acting upon that parasympathetic secremotor system and drying up the saliva. Like Botox injected anywhere, it will eventually wear off, so it'll last about 3.5 to 4 months. I have patients who like that they're not drooling, complain that they have a cotton mouth afterwards, and it's important to impress on them the importance of oral hygiene when they again have lost the benefits of some of the saliva. The National Parkinson's Foundation a number of years ago created this little kit, which they called a hospital kit, a hospital preparedness kit. And I thought that we as speech pathologists should give patients a swallowing preparedness kit to build a defense mechanism. And it should include strategies for oral hygiene, aspiration and reflux precautions, early referral to a swallowing therapist, adherence to medication schedule. I think we can play a real important role there. Adherence to swallowing exercise and figure out the best way to help patients do that. Respiratory muscle strengthening, I think every patient could benefit early or late in the disease. And just general exercise, the more we are mobile, that's the best prevention of pulmonary sequela. If you are someone listening tonight with Parkinson's, again, important if you are hospitalized for any reason to notify your neurologist, notify the hospital and nursing staff regarding your medication schedule. It used to horrify me when I worked in a hospital and that I would hear a nurse saying that, oh, I'm an hour late with my 9 o'clock meds, or a patient in a nursing facility who gets taken into the lunchroom at noon for a nice high protein meal, and at 12:30 the nurse comes in to give them their 12 o'clock carbidopa, so they get no benefit of the medicine. They start their meal in an off state. So speech language pathologists, the more we understand about these pieces, I think can be so instrumental in educating staff and helping patients. And then, believe it or not, I'm done here. Last slide. Just a few comments. So that's my dad on the right. It's actually about 20 years ago. He's passed away about 18 years ago, and even though he worked till he was 80, had Parkinsonism, and so was experiencing physical decline, and sadly died in the hospital, and had been placed on a puree diet, and he was refusing to eat. And when I called him during that period of time to, read him the riot act about how he needed to eat and what would happen, and I couldn't understand what he was saying to me. When I finally understood what he was saying, he said the food was slop. And, unless you're Diane Wolf, the puree gourmet is fixing your puree meals. Probably most of us have laid a tray before a patient that looked like slop. But my point really is that I think we need to really enlist our patients in their treatment plans, no matter what point they are in a disease process. It's said by ethicists that we as providers should never use quality of life as a criteria for why we do or don't do something, because really the only person who can make that judgment is the person who's living the life. And just like life itself, evaluation of quality of life can change. Interestingly, when you look at the literature, it shows that it's more common for healthcare providers to disagree or have disagreement with patients about healthcare decisions than to be in agreement. So I think, again, we as speech language pathologists are in such a unique position because of our role with communication and our role with dysphagia management to really be the ones to enlist patients in those conversations, particularly patients that have neurodegenerative diseases. For any of us, we should have advanced directives, but really helping patients think about some of the what ifs while acknowledging that we can all change our mind. And if you're someone listening tonight that has Parkinson's or your care partner, hopefully you have had those discussions. Because the more clarity you have, it makes it easier for the providers also to be able to provide care that supports your choices. So this is your handout, key points. You can share that with your patients or share it at a support group if you're someone with ED. Thank you so much to NFOSD for the invitation to present this information tonight. June is Dysphagia Awareness Month, so I hope that you'll give them another extra donation beyond the registration tonight. And finally, let's encourage our patients to get referrals to speech pathologists for swallowing evaluations early in their diagnosis. If you're someone listening tonight with PD, you've never yet seen a speech pathologist for a swallowing evaluation, I hope you'll request that. Sorry to go over and appreciate your attendance tonight. All right.
Mary, do you have time for a few questions?
I'm happy to take questions, yep.
So a few dozen questions came in, and you answered the vast majority of them. There were a lot of questions around exercise, EMST. So I'm going to try to focus on a few that you may not have answered.
Okay.
With respect to the best, what is the best time to take medicine to get the maximum impact of that medicine?
Yeah, so every patient, of course, is going to have their own schedule. With carbidopa, it is, I would say, kind of the, well, I can't even say the most typical. Some patients are taking it 6 times a day. Some patients that are kind of newly diagnosed may be taking it 4 times a day. What's really critical is that they adhere to those schedules, though. So what happens is when they take the carbidopa, and again, it's going to depend if they take it on an empty stomach, it's going to get in the intestine pretty quickly, and so they're going to get the effect pretty quickly. Some patients get very nauseous from carbidopa, particularly when they first start taking it. So they may say to their doctor that they just can't, first thing in the morning, they can't take it on an empty stomach. So they may take it with a little bit of food. Otherwise, usually it's recommended they take it about 30 minutes before a meal. If a patient has, again, a fairly heavy meal, it may take 2 hours for that carbidopa to actually get into the system, because it's going to have to, the food's going to all have to be digested. So, you know, I ask patients, if they haven't brought it in with them, to bring in their medication schedule. And then every visit, again, whether it's for voice or swallowing, I ask them, well, when was your last medication? Particularly if they are reporting off and symptoms. And sometimes that hasn't really been explained to patients, so they don't even know how to recognize that. So again, when the carbidopa is acting in the system, they're going to have some improvement in symptoms. If it's tremor, probably a reduction. They may be moving more easily. But as that medication begins to wear down, they may have freezing as a wearing off symptom. They may have anxiety as a wearing off symptom. They may have fatigue. That may be when they start falling asleep in front of you as a wearing off symptom. So again, you know, we see patients all different days of the week and different times if they're in a nursing facility. We actually have maybe a little bit more control of that, making sure that their medications and meals are better synchronized.
Do you recommend the use of biotin spray for dry mouth or dysphagia?
Yeah, I have patients who use it. Again, ironically, I have a patient who had Botox for drooling and uses biotin. Like, that's a bit of an oxymoron, isn't it? But, you know, my preference always is I tell people water's the best thing. Even carrying around a little travel size spray bottle with water and they can just spritz their mouth. But yeah, you know, patients do biotin.
Here's someone who's asking a question about a patient who has is unable to produce intraoral pressure, and so is there any way to improve a flaccid soft palate?
Well, I guess, yeah. So if they have that, from Parkinson's, a patient with a Parkinson's diagnosis?
The question doesn't say, but I'm assuming so.
Okay, I'm going to say some patients with PSP, progressive supranuclear palsy, have more upper motor neuron kinds of symptoms, so they might have hypernasality, occluding their nares to make sure that they're not having a significant amount of airflow, just losing it through the nares, so they can't generate intraoral pressure. But I don't know of strengthening exercise that is specific to the palate. That's just that I don't know, but I know that they're, I can't think of his name, but they're David something, but where CPAP is used, and that's more for speech, and patients do speech sounds against that pressure of air, which is stenting the palate. But yeah, I don't know.
Hey, Mary, I want to thank you for volunteering your time tonight.
Thank you.
And doing a really outstanding job on a deep dive into this. It was very informative. And I also want to thank Elizabeth Lipton-Daly for putting this together, answering many of the questions that came in, handling the registration. Elizabeth, do you mind putting up my last slide?
Sure. Give me 1 second.
Okay. And while she's doing that, I just want to thank everyone for joining us tonight. It's been really our pleasure to present you with this information. It's what we're here to do. So thank you. And within the next hour to a day, you should get an email with a survey that literally takes a minute to fill out, plus some of the links that you may have that may come in handy tied to Mary's presentation. So with that, we're going to sign off, and Mary, again, thank you so much for joining us tonight.
Thank you, Ed, and thank you everyone for your attendance. It's appreciated. Thank you.
Good night, everyone.